right, well, we'll go and get started. Good morning, everybody. Welcome to Case Sleep Medicine Grand Rounds, and it's a pleasure to have Dr. Anna May, one of our own, here at UH in the Cleveland VA, talking to us today about health disparities and in sleep.
Well, thank you so much for inviting me. I really appreciate it. I do have some disclosures. I received payment for DSMB participation in LevoNova PLC. So the objectives of this talk will be to describe the impact of social determinants of health on sleep health, to discuss current barriers to sleep apnea diagnosis and treatment, to identify factors affecting adherence to sleep apnea therapy, and to explain recommendations from the American Thoracic Society policy statement on improving sleep apnea care. So the first thing is I want to make sure that we all understand what the difference is between health equity and equality. All right, equality is giving everyone the same thing. This sounds fair, but may not be fair because you're not starting from the same place. Equity is giving each person what they need. This is leveling the playing field. Equality sounds fair, equity is fair. Health equity is the attainment of the highest level of health for all people. Achieving health equity requires valuing everyone equally with focused and ongoing societal efforts to address avoidable inequalities, historical and contemporary injustices, and the elimination of health and healthcare disparities. Health equity is social justice in health, as Paula Braveman said. This is just another illustration of the same concept, but with bicycles. So what you see here is 3 different sized people and 1 handicapped person who, the bike is too small for the big guy. It's too big for the little guy. And the person in the wheelchair can't use it at all. So that's equality. Everybody gets the same thing. Equity, everybody gets something different. You can see that the small person gets a small bike, the medium person gets a medium bike, and the large person gets a large bike, and the handicapped person gets a hand bike. All right. So the next thing I want to discuss is what are social determinants of health? Social determinants of health are the circumstances in which people are born, grow, live, learn, work, and age. And they're shaped by a set of forces beyond the control of the individual. Structural determinants affect pay, working conditions, housing, and education. In short, they affect whether the resources necessary for health are distributed equally in society or whether they are unjustly distributed according to other factors such as race, gender, social class, geography, sexual identity, or other socially defined group of people. So this is an illustration when you think about structural determinants and social determinants of health inequities. So you can have here socioeconomic and political context on the very left-hand side. So things that are general in the culture, right? And you have socioeconomic position, secondary class and gender, ethnicity, education, occupation, income, all of those affecting those. But in addition, they affect other things like intermediary determinants of social determinants of health. So like, for instance, living conditions, right? Material circumstances, behaviors and biologic factors. For instance, some groups distrust the medical system for particular reasons, and psychosocial factors. And all of those impact on health equity and well-being. All right. Intermediate determinants of health include material circumstances and psychosocial and behavioral characteristics, as well as living and working conditions of people, such as their pay and access to housing and medical care. So you can see I've listed some of these here on the left-hand side. So things like food security, housing, neighborhood environment, early childhood development, and access to health services would be considered social determinants of health, and they would be intermediate determinants of health. I think I skipped one. All right, so I think it's really interesting to know that 80% of what makes someone's health is determined by what happens outside of the hospital and health clinic. And over 80%, the largest segment, is made up of the social determinants of health. So you can see here that you have your socioeconomic factors, which are 40%, your health behaviors, which are 30%, and your physical environment, which is 10%. So in total, that's 80%. So when we think specifically about sleep care, then all of these things still affect the care provision for people. But we want to also think about things like shift work and limited sleep opportunity, access to the phone and internet, because some of our devices are internet connected and you get most benefit when you have an internet connection, digital literacy, communication style and cultural health beliefs, comorbid anxiety, PTSD, depression, and insomnia, which affect how people use their PAP machines. Crime, violence, social cohesion. So some of these are kind of more general and some of these are more specific to sleep. Does that make sense to everybody? Yes, I'm going to take that as a yes. All right, so I wanted to talk about systemic and structural racism. Systemic racism is involvement of whole systems, including the structures that uphold those systems. So for instance, the political system, legal, economic, healthcare, school, criminal justice. Structural racism emphasizes the role of structures such as laws, policies, institutional practices, and entrenched norms. Systemic racism includes structural racism. So an example of systemic racism is residential segregation or redlining. So this is a map of redlined districts in the 1930s on the left-hand side. And many of the Cleveland neighborhoods are banks redlined almost a century ago and have the city's highest rates of poverty and crime. Although the lending practice of rejecting mortgage applications in specific neighborhoods more accurately to minorities was banned more than 50 years ago, the effect of this so-called redlining is still felt today. Racial segregation is almost always accompanied by concentrated economic disadvantage and limited opportunities for upward mobility, such as good employment options and good schools. Because of segregation, African American and Latino people are more likely than white people with similar household incomes to live in neighborhoods with concentrated disadvantage. Those adverse health effects have repeatedly been demonstrated, yet most health and medical studies do not include variables representing neighborhood conditions. The consequences of this state-sanctioned racism are higher rates of poverty, unemployment, and low home ownership in non-white communities. Due to the chronic economic and social deprivation of these areas. This segregation has long-lasting health impacts as neighborhoods have been associated with cardiovascular health, cancer risk, and outcomes, and infectious diseases such as tuberculosis and SARS-CoV-2 pandemic. So another example of environmental injustice, which deals with locating hazardous waste disposal near minority communities or building other disadvantageous businesses near minority communities, is Flint, Michigan. In 2014, the officials in Flint changed the city's water source to cut costs, but the change in water source induced erosion of old lead pipes. They knew this and still went forward with it. The resulting widespread lead poisoning among children. City officials were then repeatedly ignored residents' concerns, and the Flint water crisis reflects a long history of segregation, divestment in infrastructure, and officials ignoring Black residents' concerns with devastating long-term health impacts for those children. Oops. I have a criminal justice example as well. But that is things like discriminatory policing and sentencing practices, police violence, and school to prison pipeline. So police violence is a leading cause of death in young Black men in the United States, and approximately 1 of every 1,000 Black men is killed by police. Also, Black victims killed by police are more likely than white victims to have been unarmed, suggesting disparate treatment. Police killings of Black men have been associated with worse health of entire statewide Black populations. The school to prison pipeline that I mentioned refers to the phenomenon in which children, mainly, but not exclusively boys, of color are systematically disciplined more harshly, including suspension and expulsion from school, than more other children for behavioral problems warranting counseling and support rather than punitive measures. Police are more likely to be called into schools to deal with misbehavior by students of color, and suspensions, expulsions, and police involvement greatly raise the risk for incarceration. So there is also a concept called weathering, and basically this is when premature aging and cellular dysregulation of cells, tissues, and organs and body systems because of chronic stress. So you can see here that systemic inequality leads to weathering, and it's a cumulative effect over time. So you can see that there's like individual ones, there's cultural systems, ideologies, and resource allocations, and all of that leads to the biology environment interactions. So for instance, you interact with your neighborhood, right? And then also physiologic adaptation or disruption based on your stress response, which with increased allostatic load and cellular aging and disease risk, which leads to health, life expectancy, and inequity. All right. So this is chronic activation of the fight or flight system, and it leads to increased and earlier rate of diseases and lower lifespan in marginalized community. So I mentioned allostatic load, and that's the cumulative burden of chronic stress and life events. So when environmental challenges exceed the individual's ability to cope, the allostatic load overload ensues. Systemic and daily low-level racism, discrimination, and economic deprivation all contribute to weathering. The next thing I want to talk about is sleep time health inequities.
Where the term weathering came from?
What's that?
The term weathering came from?
It was made up by the guy who just like thought of the concept.
I see. Wonder how they thought of that. Okay.
It's kind of like, you know, if you've ever had plastic chairs and you left them outside, right? They become brittle over time just because of the elements. That's weathering in structures. This is weathering in people. So it's a similar kind of thing where it slowly breaks it down because of external factors. So here, external factors are things like social determinants of health, right? And, health and
no, I understand once you gave that analogy. Or is that, it's an analogy. This is.
All right. So discrimination does affect sleep. There is systemic racism and discrimination, acculturation, stress associated with insomnia, and shorter sleep duration and worse sleep quality. So in the sister study, women were reporting major discrimination, had shorter sleep and more insomnia symptoms. And increased racism-related vigilance is associated with sleeping difficulties and delayed sleep onset. Institutional racism and implicit bias is built into the healthcare system, and lack of concordance in race and ethnicity of providers leads to friction in the provision of healthcare. Few underrepresented minorities in sleep medicine. So it's a real problem with the pipeline of sleep physicians that we have. All right, here is a display of neighborhood environmental factors that can improve or threaten sleep. There are protective factors on the left and detrimental ones on the right. Some of these factors affect the comfort of the sleeping environment, like loud sounds, bright lights shining through windows, making it more difficult to sleep. Other features, like the presence of litter and abandoned homes or properties, pose safety hazards and increase stress over possible ne'er-do-wells taking up residence or increasing the risk of burglary or other crimes. Crime can make people feel unsafe in their house via two mechanisms. First, crime directly decreases sleep by increasing worry about home invasion, leading to hypervigilance. And second, post-traumatic stress disorder can develop in some who have been victims of crime. One of the key things in PTSD are that you have recurrent nightmares or sleep disorders, mostly insomnia. With PTSD, you have hypervigilance, and that can decrease and disrupt sleep as well, because you wake up much more easily and you tend to get out of bed rather than going back to sleep. And what I like to call patrol the perimeter, which is where people check all their locks and make sure all their doors are closed and their windows are locked, etc. In addition, excess heat and noise are really detrimental to sleep. The lack of tree cover in urban neighborhoods, where racial and ethnic minorities are often clustered, means the environment is up to 4 degrees higher than shaded high-income streets. And racial segregation due to racist housing policies has led to urban heat disparities. With the effects of global warming, these red-line neighborhoods are at risk of being urban heat domes. So super hot in those neighborhoods. The social environment also contributes via chronic fear about safety and low social support in neighborhoods, leaving less mental bandwidth for other issues, such as more difficulty sleeping. This decreases the restorative power of sleep, additionally adds to worse memory, vigilance, and possible cognitive decline in the long term. Safe housing conditions are associated with objectively better sleep, higher sleep efficiency, and lower wake after sleep onset by actigraphy. Those living in neighborhoods with lower social cohesion and more violence concerns had shorter sleep and lower quality sleep. Prior observational work suggests that neighborhoods with more tree canopy, water features, and green space have higher average sleep time. And neighborhood greenness is also associated with decreased perceived stress and cardiovascular disease. In contrast, those with neighborhood deprivation, like more urban noise, litter, blight, or crime, engender more sleep disturbance and shorter sleep time. So we find that Black people are more likely to be short sleepers, which is defined as less than 6 hours a night. Black Americans have 2.5 the odds of sleeping 5 to 6 hours a night compared to white Americans. Asian and non-Mexican Hispanic Americans have an odds ratio of 2 to 3 for sleeping less than 5 hours. The National Health Interview Survey showed that Black people report sleeping less than 7 hours a night on average. And neighborhoods with more tree canopy have higher average sleep time, which I already mentioned. So next we're going to talk about sleep apnea. So there are numerous symptoms of sleep apnea that are on the left, and then things that sleep apnea is associated with on the right. So it's really important to understand that different people will have different symptom clusters for sleep apnea. So some people might have the really classic snoring, obesity, witnessed apneas, and other people might have more things like insomnia and depression. In addition, it's important to consider associated symptoms and to evaluate for those as well, particularly in the primary health setting once sleep apnea is diagnosed. Sleep apnea is very highly prevalent. You can see that, for people that are, for both men and women, they have a relatively high prevalence. However, women tend to have less severe sleep apnea, and they have less sleep apnea when they are less than 60 years old. And that is because menopause tends to make sleep apnea more prevalent. The other thing is that
Is that a
people,
community study, Anna?
yeah,
Or the previous one, is that community-based or is that across the country or is it more local?
this is a specific study, and it is, I think, across the country.
Okay. All right.
So 80 to 90% of people are undiagnosed. The heart health study found that 10.5% of people with snoring and sleepiness were diagnosed with sleep apnea, which is clearly an underestimate. The Wisconsin sleep cohort showed that 2.5 to 4% of people were diagnosed with sleep apnea. But adults have, in the middle ages, 27% of men and 11% of women have sleep apnea. So clearly there is like mass underdiagnosis of this. And it takes on average about a decade to get sleep apnea diagnosed. So why are 80 to 90% undiagnosed? So there's several different factors. First of all, primary care clinicians are busy. Most health insurance requires you to have a referral from a primary care physician, or at least a lot of them do. And so the primary care physician has to identify that you have risk factors for sleep apnea and send you to sleep medicine, who will evaluate you. And clinicians are really busy. They have 5,000 things on their plate, right? From every specialty, wanting to have XYZ done for their favorite condition. They have a really complex population with multimorbidity, and they have also acute presentation of problems where somebody comes in for instance, back pain. That was super common. And then we also have patient underreporting. So a lot of people think it's just a fact of life that they snore. Some people think that is actually it indicates quality of your sleep, and that if you snore, you have better sleep. They don't know that anything is wrong with snoring during sleep, and they don't bring up poor sleep for years. So in the, let's see here. So there are higher rates of sleep apnea in Black adults, as well as daytime sleepiness, snoring, and more severe sleep apnea. And the Jackson Heart Study, which specifically studied African Americans, 24% had moderate to severe sleep apnea, and 95% of individuals were undiagnosed. A prospective study of 512 patients with full night PSGs showed higher AHI in Black patients, with the average being 32.7 in Black patients versus 22.4 in white patients. And it might be that there is a higher rate as well as more severe, at least more severe sleep apnea, because people are not seeking care because of mistrust in the medical system and cultural attitudes. So it's at a later stage. In addition, just like with diabetes, where we know rates are higher in certain populations, it might be that sleep apnea prevalence and severity is higher in these minority populations. All right. Social ecological factors contributing to health disparities at multiple levels. So you can see here that there is the neighborhood and broader socio-cultural factors that we talked about. So like insurance coverage and neighborhood cohesion, access to care, light and noise. There's family factors, which are much more narrow, right? So for instance, your family structure. Do you have a parent, like one parent, or do you have two parents, or do you have a whole community that's looking out for you? Resources, like some people do not have the ability to have an individual bed or an individual bedroom. And so if you have multiple people in the same bedroom, it's A, hotter, B, noisier, and that decreases your ability to sleep well. There's also beliefs about sleep and health, which can be both in the neighborhood and broader socio-cultural factors, as well as specific family factors. So it kind of fits in both. There's also individual factors like race and ethnicity, your immigrant status, your temperament, your biology, and your genes. And all of these have interactions with your health and well-being, which oftentimes will predispose you to particular sleep problems like sleep apnea or poor sleep health. The next thing I wanted to talk about was neighborhood segregation and disparities in PAP adherence. So segregation leads to economically deprived areas, as we previously talked about. There's increased crime, violence, and decreased social cohesion. There's increased housing instability and poverty in these neighborhoods, and increased noise, heat, and light pollution, as we previously mentioned. And so this affects the person. As far as personal factors, you can think about comorbid psychological disorders like anxiety, PTSD, depression, and insomnia, mistrust of the healthcare system, and then shift work or other issues as far as multiple jobs. So treating sleep apnea. So we know that there are many modalities for treatment of sleep apnea. The most popular of which is positive airway pressure, and we have a bunch of different modes of that. However, oral appliances, nasal resistance devices, tongue protrusion devices, and hypoglossal nerve stimulation, as well as phrenic nerve stimulation and tracheostomy, are all potential ways of treating sleep apnea. Obviously, we very rarely do tracheostomies nowadays, but that actually was the standard of care approximately 40 to 50 years ago, before CPAP was invented. So you can think of adherence to medical therapy as a multifaceted process with significant contribution from contextual factors. So what are contextual factors? They're like your socioeconomic status, right? Your interaction with the health system and the provider. In addition, there are patient factors, treatment factors, and condition factors that affect your adherence to medical therapy. What does that mean? So like, for instance, HIV has a lot of bias to it. And so oftentimes people will not get tested for HIV because of the stigma associated with it. As far as treatment, more onerous treatment leads to less adherence. So if you have a medicine that you need to take 3 times a day versus a medicine that you need to take 1 time a day, you're much more likely to be adherent to the medicine you need to take 1 time a day, just because it is much easier. So we define adherence based on the Centers for Medicare and Medicaid Services threshold, which is 70% of nights, at least 4 hours a night. And there is a dose-response relationship with cardiovascular events, blood pressure, neurocognitive outcomes, and quality of life. So we encourage people to use their PAP machines the all night and with naps. Right. So there is problematic adherence across the board. A meta-analysis of 569 studies of adherence showed that there is approximately 25% overall non-adherence to medications. The adherence is lowest in diabetes, pulmonary disease, and sleep, and highest in HIV, rheumatoid arthritis, GI disorders, and cancer. When we think about things that are in pulmonary, like asthma, the non-adherence rate is 30 to 70%. And this actually accounts for 75% of total asthma cost. When we think about sleep medicine, there is a non-adherence of 40 to 50% to PAP therapy. And this likely contributes to significant healthcare costs, which has been shown in cost effectiveness analysis, where in analyses that look at healthcare costs for people before and after treatment. So just a little humor. There is no sleep apnea fairy, unfortunately, to put on your CPAP. So you really have to take charge and put the machine on your face. But there are a lot of factors that can contribute to make it harder for you to do that. Adherence to CPAP is associated with residential features. What does that mean? So neighborhoods with lower socioeconomic status and predominantly non-white residents, like for instance, in our red line districts in Cleveland, have worse adherence to CPAP. Residing in a neighborhood with greater than 25% Black or Hispanic residents was associated with fewer minutes of CPAP use versus neighborhoods with less than 1% of non-white residents. Randomized controlled trial of home sleep apnea test versus PSG. There was a 92-minute per day less PAP use among Black participants. And in a randomized controlled trial looking at PAP versus sham PAP, there was 75 minutes per day less, worse, and particularly worse in women. In the Chicago observational study, there was a 56-minute per day lower adherence in Black participants. And that, I mean, that is actually huge, because a lot of our interventions for adherence will improve adherence by, let's say, 30 minutes on average. And so having a disparity of 56 to 90 minutes is huge. And if you think about an hour and a half more of using your PAP for somebody who sleeps for, let's say, 5 or 6 hours, and that is pretty common among minorities, that is a significant chunk of their sleep time. There are also veteran affairs studies. So there is an observational study from Miami, and it showed 1.6 hours less of PAP use in Black participants. There's also one from Tampa, where Black vets were half as likely to use PAP compared to white people. And from Los Angeles, they had lower odds of CMS adherence threshold in Black compared to other races, even after adjustment for neighborhood socioeconomic status. In the VA overall, there is less adherence than in the non-VA population. So for instance, if adherence estimates for initial 90-day adherence is 70% to 80% in non-VA people, overall, it is approximately 40 to 50% in the VA population. So it is systematically lower in the VA population in all of the studies that have ever measured it than in the non-VA population. All right. There are also disparities in PAP adherence due to systemic bias. What does that mean? So there is significant mistrust in the healthcare system, and it is not unjustified considering that Black people have been unfairly experimented on in the medical setting in the past. A great example of that is the Tuskegee experiments, which were extremely unethical and led to a significant mistrust of the healthcare system by African Americans that is present until today. So I still have patients that say, I don't want you to experiment on me, even when I'm saying, hey, let's try out XYZ, and it's an approved therapy. Also, racial segregation affects PAP adherence. And I think that is important to note. So neighborhood composition is associated with CPAP adherence, and zip code, age, sex, and age-adjusted and zip code socioeconomic status adjusted population. So you can see here on the bottom is neighborhood minority composition, starting from less than 1% and going all the way up to 25%. And on the y-axis, what you see is the percent adherence to CPAP. And so the blue line is white people, like an average of 70% or so, right? And the Black people, the increasing population, you see that you have decreased adherence. So there's a difference in CPAP use by neighborhood, race, and ethnicity. Oops. And the more people you have that are segregated, the less adherence that you have. There are several neighborhood features that affect CPAP use. So for instance, psychological distress, such as stress, anxiety, and concern with neighborhood disorder and crime, delayed or fragmented sleep due to noise and light pollution, as well as contributing to insomnia. So we have previously talked about increased rates of insomnia within the minority population, as well as decreased sleep time. There is increased difficulty getting to sleep and poor sleep quality as well. And there is less total sleep. So because people sleep less by a percentage portion, if you, for instance, spend 50% of your time with your CPAP mask on and you sleep for 8 hours, that's 4 hours, and you are actually meeting the threshold for Medicare. But if you sleep for 6 hours and you're still at that 50%, that's only 3 hours and you're not meeting the Medicare standard. There's also poor tolerance to CPAP use in some populations. All right. So as far as access to care, we can think about health and digital literacy, language barriers, access to internet, Wi-Fi, telemedicine, being able to use those services, transportation, shift work, childcare, and sleep opportunity. So health beliefs explained 32% of the variance in adherence in 77 CPAP naive patients. There was a difference in outcome expectation, risk perception of therapy, and functional limitations secondary to sleepiness. Black people have maladaptive beliefs about sleep. It is more common in those at higher risk for sleep apnea, unfortunately. So the higher your risk of sleep apnea, the more common it is to have bad beliefs about sleep, such as snoring being a quality measure of sleep. And it is often seen as a personal failing rather than a symptom of a disorder. That person is just lazy rather than that person has excessive daytime sleepiness because they have a sleep disorder. There's also distrust of the medical community. So I'm sure all of you are familiar with the Tuskegee syphilis study, which I have previously mentioned a couple of slides ago, which has led to a significant distrust in the medical community among African American population. Basically, in order to study natural disease progression, this study withheld treatment from Black men until 1972, even though penicillin, which is the treatment for syphilis, was invented in 1943. All right, that is nearly 30 years. And that's just the most recent in a slew of immoral biomedical experiments inflicted on Black Southern populace. There were a lot of experiments actually on Black pregnant ladies as well, a lot of obstetric care. For instance, forceps were initially developed on the African American population, as well as treatments for like different vaginal tears after pregnancy. All right, so how can we improve equity in CPAP use? So we've thought long and hard about this and come up with a statement. It is called Moving Towards Equitable Care for Sleep Apnea in the United States. And it specifically deals with positive airway pressure adherence thresholds. So one concept is using accountable communities for health, which are called ACHs for short, which are multi-sector community-based partnerships that bring together healthcare, public health, social services, and other local partners, as well as residents, to address the unmet health and social needs of the individuals and communities they serve. So you can think of the community as a whole, right? And having all sorts of the disparate parts. It's kind of like when Black churches have vote gathering efforts where they will go to the polls all together, right? That is a way of incentivizing the community to vote. And it's a similar concept in health. So for instance, having a health screening fair that is sponsored by a significant community organization can significantly improve the screening for a particular disease. The other thing is we recommend redefining PAP adherence as consistent long-term use of PAP therapy that yields sustained patient benefits. So what does that mean? So that's less daytime sleepiness, improved quality of life, more daytime energy, greater sleep quality, things like that, over a 6-month period. We favor patient-centered definition on the basis of goals rather than specific time use cutoffs to define adherence. However, a reasonable minimal PAP use threshold, if you need to like really pin me down, would be 2 hours a night averaged over a 6-month trial to continue coverage. One of the things that we have found is that people who are minorities take longer to become adherent than white populations. All right. So things like consistent patient intent to use, forward progress towards usage consistency and frequency would qualify as goals that would define adherence. And the ultimate goal, as we previously said, is consistent PAP use for the entire sleep time, including both the main sleep period as well as any naps. So before therapy initiation, a clinician should educate the patient on all reasonable treatment options and then collaboratively decide on therapy. Personalized adherence targets should account for patient-specific factors such as comorbidities, contextual factors, social and economic conditions, and unique circumstances. Initiation of preemptive adjuvant therapies before starting PAP can be useful in patients that you anticipate to have challenges with PAP. So several domains, including psychiatric, so people with anxiety and PTSD, comorbid sleep disorders such as insomnia or nightmare disorder, claustrophobia, cognitive dysfunction, or limited dexterity or mobility have a negative effect on PAP adherence. And so perhaps getting those people additional aid, even before you start on therapy, can be helpful in achieving adherence thresholds. Identification of these factors can facilitate targeted therapy referral. Cognitive behavioral therapy for insomnia can facilitate PAP adherence in those with comorbid insomnia and allow faster adoption of PAP. Integrating rehearsal imagery for nightmares and PTSD, acclimation, motivational interviewing, and other behavioral interventions, in addition to a short supportive trial of PAP, like PAP naps, may improve PAP adherence in populations with psychiatric comorbidities. So having people try it out and see that it's not so scary can really improve people's use of the machine. There are actually a significant number of patients that take the machine home and just never use it, never take it out of the box, basically. Addressing limitations on time, access to mental health care, and added costs will also be crucial to implementing these referrals. Improving PAP tolerance through gradual acclimation, behavioral change, and desensitization often requires extended time, which is why we think 6 months is a reasonable time point, whereas 3 months can sometimes be too short. And this is particularly true in under-resourced populations. All right. The other thing is timely communication with the DME regarding adherence issues. So initial PAP therapy impressions are important, and additional time should be spent at therapy initiation to discuss goal setting, troubleshooting, and answering questions. Early adherence is indicative of long-term adherence, and studies suggest that patterns are set in the first week of therapy. So early intervention has the best chance of improving long-term adherence. Common early adherence issues include poor mask fit, nasal and oral dryness, and pressure discomfort. The DME provider staff can solve these issues with additional mask options and setting adjustments for comfort. Poorly fitting masks are the most common cause of PAP therapy side effects. So understanding those and treating them can be a real boon for PAP adherence. Allowing an at-home trial of up to 4 masks would improve the probability of finding a well-fitting mask at therapy initiation. It's hard to define de novo which mask is going to be the most comfortable for a patient. It's difficult to do that. So you can have an educated guess, but there are a lot of people that switch masks. However, currently there's only 1 mask per 90-day period. And so you really only have generally 1 mask to try out before you're evaluated for your adherence. Communication between DME providers and clinicians for intervention coordinated and enhancement enables early problem solving. DME providers could identify the best mode of communication on the best basis of patient preference to facilitate timely care. And some people become categorically opposed to PAP, and that's okay. We have other treatments for sleep apnea. They have no intention of using PAP. And so early return of devices frees up inventory to treat other patients, reduces waste, and decreases monitoring follow-up burden to staff. So we encourage people to return their PAPs early if it's not working for them, if they absolutely know, I'm never going to use this. All right. Patients are not able to reach adherence goals for multiple reasons. If a patient wants to continue therapy but is not meeting adherence goals to signal their resolve and motivation, they can partake in a targeted adherence program. What does that mean? So that's like a PAP nap or an educational session or a webinar or joining peer buddies or group or individual behavior therapies or outreach visits, things like that. But in-lab polysomnography does not increase PAP adherence and creates burdens and barriers because of transportation, shift work issues, issues with childcare, et cetera, and adds wasteful cost and time delays. Monitoring and early intervention effort expansion can be challenging for DME providers because of the increased workload. And so this workload needs to be distributed among more personnel. So workload for follow-up coaching and troubleshooting can be offloaded via care delivery innovation. I'm sure people can come up with additional ways of providing this care. And despite modern telehealth innovations improving adherence, their impact is in disadvantaged groups because these tools require internet access, English fluency, and medical literacy, as well as digital literacy. Multifaceted approaches based on patient preference is likely to increase PAP adherence and improve the use of therapy. All right. So in summary, social determinants of health are a major driver for health outcomes. There are numerous structural and intermediate determinants that impact on health and specifically on sleep health. Minority groups have worse sleep, including decreased sleep time, worse quality sleep, increased prevalence of sleep apnea, increased severity of sleep apnea, and worse adherence to sleep apnea therapy. Thank you. I'm happy to take your questions now.